Hello, my name's Trent. I graduated from Imperial and am now an FY2 in Glasgow. We're going to talk about blood pressure, when to worry about it, or not, and what to do. This is aimed primarily at new doctors, though for medical students, I hope it helps to explain why all that physiology matters. We'll remind ourselves what blood pressure is, go through the reasons it might be low, and from those come to an approach you might take. We are going to move quite quickly, so if there's something you want to look up, feel free to pause the video and come back. Low blood pressure is one of the most common things to be asked or paged about as an FY1. So what is low? For our purposes, the definition is a systolic blood pressure of less than 90 millimeters of mercury, not 110 as news charts would lead us to believe. However, and I cannot stress this enough, remember that everyone's normal is different. A normal blood pressure might be too low for someone who's usually very hypertensive, and a small old lady might happily sit with a systolic of 85 all the time. Blood pressure is a product of the heart rate, stroke volume, and systemic vascular resistance, or the cardiac output and how constricted or dilated the blood vessels are. So changes in any of these can affect the blood pressure, and changes in the other ones are how we compensate. So what happens when we can't keep our blood pressure up? The ultimate consequence is shock, meaning inadequate tissue perfusion. This is when hypotension is a problem. But let's talk about the reasons it might have happened. If we can work that out, it's much easier to know what to do. The four classical types are cardiogenic, hypovolemic, obstructive, and distributive. And we'll mention some others for bonus points too. You can turn them into an acronym if that suits you. Maybe the heart isn't pumping enough blood, like if the heart rate's too low, or if it's too high and there isn't time for the ventricles to fill. Do we know that the patient has heart failure? And if they're currently having an MI, there will hopefully be some other signs or symptoms. Maybe there isn't enough blood to pump. Hemorrhage is the first thing you'll think of in a surgical patient. The other really common cause is GI bleeds. Dehydration is the other big cause of hypovolemia, so let's look into it a bit further. We all love regurgitating how to clinically assess volume status, but it's been well established that the signs we know and love are not reliable enough. Even the blood pressure. Standing the patient up can help, if that's possible. But the most reliable way is to compare their current renal function to their baseline and to monitor their fluid balance accurately. Now this is notoriously difficult, but we shouldn't be allowing inpatients to become dehydrated. Having a word with the nursing staff and helping to remove any obstacles to accurately monitoring the fluid balance might just be the most helpful thing you could do for that patient. Obstructive shock means something is stopping the blood from getting through. It would be unusual for hypotension to be the only sign of a tension pneumothorax, tamponade, or a massive PE, which is why information like the other observations is so important. Cardiogenic, hypovolemic, and obstructive shock cover the cardiac output and stroke volume, so if they're okay, the vascular resistance must be the problem. Distributive shock is a class of its own because the problem is not a lack of fluid, it's that the fluid is in the wrong place. Liver failure can cause this in multiple ways, such as low albumin and ascites. Anaphylaxis, and the one you've all been waiting for, sepsis, are both related to cytokines. Since sepsis is quite a hot topic, let's clear some things up. The release of cytokines leads to the heart not pumping as efficiently, a reduction in the systemic vascular resistance, and an increase in vascular permeability. The latter two result in more fluid going into the interstitium, and this is what's known as third spacing. So what should we do about it? Well, the current surviving sepsis guidelines recommend a fluid bolus at the point of diagnosis or recognition of sepsis. 30 ml per kg works out as roughly 1.5 to 3 litres. Patients with an infection can be dehydrated for various reasons, so it's important to make sure that they're not. However, beyond that, we need to think harder. A fluid challenge is typically 250 or 500 ml of crystalloid given stat, but most septic patients do not respond to this, in that their blood pressure doesn't increase significantly. This is partly due to the leaky blood vessels, which are contributing to the hypotension in the first place, and unfortunately, overloading them with fluid is pretty easy and just worsens the end organ dysfunction. So first, do no harm. If you give a fluid challenge, always reassess things afterwards and consider letting your SHO or Reg know. The NICE guidelines even recommend that a consultant should attend if a second fluid bolus has been given without improvement. Moving on. If you're still stumped as to why someone's blood pressure is so low, don't forget endocrine causes. Technically, they're combinations of the other mechanisms, but it's worth having it at the back of your mind. And last, but certainly not least, if you're worried or if it just doesn't seem quite right, always recheck the blood pressure. Non-invasive blood pressure is an estimate at the best of times, and it can be thrown further off by talking, moving, the wrong size cuff, pretty much anything. So let's put it together and think about how we'll approach things when the call comes through. Now, this is very much a suggestion, and the order is totally flexible. So first things first, numbers. You need all the observations, not just the blood pressure, and you want to know the trend, how much it's changed. Always think about it in the context of that patient and what's normal for them. You want to know how worried the nurse is. Do they look really sick? Are they symptomatic of the low blood pressure, or are they feeling totally fine? What's their current problem? What other diagnoses do they have? And something we haven't mentioned before, have they had any medication that can lower their blood pressure? Ask about their fluid balance, and if you're told it isn't being measured, try and get a sense of their intake and losses. And think about if it's worth asking for their fluid balance to be monitored going forwards. Like with any page you receive, before you put down the phone, try to think, do I want to ask for anything? Like a repeat set of obs, or lying and standing, or for the nurse to get something ready for when you arrive. If they're sick, or you're unsure why they're hypotensive, speak to and examine the patient. And remember that you're not clerking them in. So even if they look fairly well, an A to E approach is a systematic, focused way of quickly searching for the causes that we've talked about. If you do find anything that concerns you, as always, think about getting help or calling your senior sooner rather than later, even before doing any investigations. In summary, I hope this video has given you some food for thought to take forwards. If you have any questions, please comment below or feel free to email me on trent.allen@nhs.net. If you're interested in some further reading, I highly recommend A Rational Approach to Fluid Therapy and Sepsis, which is one of the articles I referenced earlier. Thanks for watching.